So, welcome, Dr. Augustus Oliver Grant. I know it's indeed our pleasure to have you, an expert in atrial fibrillation and in general rhythmology. It's our pleasure to have you, and then we look forward to learn from you on your perspectives on atrial fibrillation management. I am Dr. Ullas. I am Chief of Department of Electrophysiology here at Chennai, Madras Medical Mission Hospital. I am joined by an eminent and a senior neurologist from Mumbai, Wokar's Hospital, Shirish Haskar. So welcome, Dr. Shirish, and I think it's our pleasure to invite Augustus to talk to us about his perspectives on atrial fibrillation management. Over to you, Dr. Augustus.
Welcome, Dr. Augustus.
Thank you for the kind introduction. What I'd like to do is to spend the first 20 to 25 minutes laying the ground to outline my thoughts about atrial fibrillation. And then it will provide a basis for having a discussion on the problem. In the lower part of this slide, it indicates what the natural history of atrial fibrillation is like. Initially, patients start with brief episodes of atrial fibrillation that may be silent. These brief episodes eventually become longer until they start having paroxysms of atrial fibrillation. We define a paroxysm of atrial fibrillation as an episode lasting 7 days or less. Later, the atrial fibrillation may become persistent, in which we have to terminate the atrial fibrillation with a drug or DC cardioversion. If the persistent atrial fibrillation lasts a year or more, we call it long-standing persistent. And then finally, in some circumstances, the physician and patient make a determination that they will keep the patient in atrial fibrillation, and in that state, we call the situation permanent atrial fibrillation. This slide summarizes the approach to management of patients with atrial fibrillation. The first thing that one needs to do is to document the presence of atrial fibrillation, and that obviously requires an electrocardiogram. However, in recent years, we have been able to document the presence of atrial fibrillation in patients who have implantable devices, such as pacemakers or ICDs, when these devices record high-rate atrial episodes. Alternatively, we may use ambulatory monitoring recording, either with a Holter type or a recording that has a longer monitoring period than the Holter. Once atrial fibrillation has been documented, one has to perform an initial assessment, and that involves identifying any associated diseases that may be encountered in atrial fibrillation. In particular, the presence of hypertension, diabetes, heart failure, valvular, and other forms of heart disease. In terms of the initial investigation of the patient, I think it's fairly standard now that we should always do an echocardiogram to determine what the ejection fraction is and to say what other forms of structural heart disease there may be. The strategy of management includes rate control and rhythm control. And we are guided by the approach that we use for rate and rhythm control by the types of symptoms that the patient has. There are some patients who are minimally symptomatic, particularly elder patients who are not very active, and under those circumstances, just anticoagulation and rate control will be appropriate. There are other patients who have marked symptoms, and the symptoms in particular often include fatigue, loss of energy, shortness of breath. When those symptoms occur, then one has to go beyond rate control and think about rhythm control or relief of symptoms. The next issue that has to be addressed is the question of anticoagulation. One should assess the thromboembolic risk of the patient and also the risk of bleeding. After that has been assessed, one makes a determination about the choice of antithrombotic therapy, which may include oral anticoagulation, aspirin, or no therapy at all. Lastly, it's important to treat any underlying disease that may be associated with atrial fibrillation, in particular, hypertension, heart failure, and sleep apnea. Also, in terms of the choice of treatment for hypertension, it's known that if you use ACE inhibitors or angiotensin receptor blockers, those therapies in their own right can decrease the frequency of atrial fibrillation. So if we go to the first strategy that one has to address is the issue of rate control. In rate control of atrial fibrillation, one makes the determination as to whether the ejection fraction is depressed or whether it's normal. In individuals who have an ejection fraction of 40% or more, one can proceed with beta blockers or diltiazem for rate control. If the ejection fraction is less than 40%, or if there are signs of pulmonary congestion, then one has to use low doses of beta blocker for rate control, amiodarone, and in either circumstance, one should also add digoxin as a means of rate control. Now, there are various levels of rate control that one may aim at. If the patient is symptomatic, then one will try to be sure that the patient gets a heart rate below 110 beats per minute and that the heart rate does not increase excessively with exercise. For patients who are minimally symptomatic, one can use a more lenient approach to rate control. Having controlled the ventricular response in atrial fibrillation, the next thing to consider is restoration of normal sinus rhythm. Here in the US, we most often use direct current cardioversion to restore sinus rhythm. If the atrial fibrillation is of greater than 48 hours duration, or if we are uncertain, then we usually recommend a 3-week period of oral anticoagulation before attempting DC cardioversion. An alternative strategy is to do a transesophageal echocardiogram to be sure that there is no thrombus in the left atrium. And if that is the case, one can proceed directly with DC cardioversion. In either circumstance, the patient should be anticoagulated at the time of DC cardioversion. One should continue anticoagulation for a minimum of 4 weeks following the cardioversion. The reason is that if the atrial fibrillation is going to recur, it most often recurs within 4 weeks of the cardioversion. A few comments about technique. One should use an anterior-posterior placement of the cardioverting leads, and it's best to use a high energy shock rather than several low energy shocks. In some circumstances, pre-treatment of the patient with an antiarrhythmic drug may facilitate cardioversion. For example, at times, if a DC shock is attempted multiple times and does not cardiovert the patient, then if you give albuterol intravenously, that can increase the success of cardioversion by an additional 10 to 15%. And just in general, if you can initiate antiarrhythmic drug therapy prior to DC cardioversion, you're more likely to get and retain normal sinus rhythm. A word or two about what to do about DC cardioversion depending on the status of the patient. If there's hemodynamic instability, this is now cardioversion for patients who have been in atrial fibrillation for less than 48 hours. If there's hemodynamic instability, then one should proceed directly to DC cardioversion. If there's no hemodynamic instability and the patient is fairly stable, then one can use drug options to restore normal sinus rhythm. If the patient has structural heart disease, the recommendation is to use intravenous amiodarone. If there is no structural heart disease, then one can use the class 1C drugs, flecainide, propafenone, or the drug ibutylide. This is a fairly complex slide, but it reviews the selection of antiarrhythmic drugs to maintain normal sinus rhythm. The choice of drugs is dictated by the status of heart disease in the patient. If we start from the far left, if the patient has no or minimal heart disease, then the options in alphabetical order include dronedarone, flecainide, propafenone, or sotalol as an initial first choice. If those drugs do not work, then the other options are to consider amiodarone or dofetilide, both class 3 antiarrhythmic drugs. If the patient has hypertension and substantial left ventricular hypertrophy, then the recommendation is to use amiodarone as your initial drug. If there is no significant left ventricular hypertrophy, then the choice of drug is similar to that in a patient with no structural heart disease. In patients that have coronary artery disease, we know that the class 1C drugs pose a risk of proarrhythmia and death, and so they're not recommended in patients with coronary artery disease. Instead, the drugs dofetilide, dronedarone, and sotalol are recommended as a first-line drug, and amiodarone as an alternative. The last group of conditions is patients with heart failure, and under those circumstances, amiodarone and dofetilide are recommended. Now, I've included at the very bottom in all of these cases, a final option is to consider catheter ablation, and that will depend on a discussion between patient, physician, and resources. I'd like to briefly outline some of the pharmacokinetic properties of the common drugs that we use. Flecainide is a class 1C antiarrhythmic drug that's primarily excreted by the kidney. It has important proarrhythmic effects where it can slow the atrial rate in atrial flutter and actually results in an acceleration of the ventricular response, or it may precipitate heart failure. Propafenone is also a class 1C antiarrhythmic drug. This drug is metabolized in the liver. It has an active metabolite. The parent drug itself is a beta blocker, and it has proarrhythmic effects similar to that of flecainide. Sotalol is a class 3 potassium channel blocking drug that's predominantly excreted by the kidney. Dofetilide is of a similar class, also excreted predominantly by the kidney. Both sotalol and dofetilide pose a proarrhythmic risk of torsade de pointe, and so one has to measure the QT interval carefully when these drugs are initiated. And we particularly emphasize admission to hospital for monitoring when initiating therapy with sotalol and dofetilide. Amiodarone is primarily metabolized in the liver. It has multiple organ toxicities, And I shall say something more about amiodarone because it is the most effective single drug that we have. The last drug to mention is that of dronedarone. Dronedarone is also metabolized in the liver. It poses a risk for patients who have heart failure, and it is one of the few drugs that we can initiate on an ambulatory basis. Some more comments about amiodarone. As I said, I'll comment more about it because it is the most effective drug that we have. It's metabolized in the liver. There are regimens for both IV and oral use. Note that in the case of the oral use of the drug, one has to load the patient over several weeks. One regimen involves using 800 milligrams per day in divided doses for 1 week, 600 milligrams again in divided doses for another week, 400 milligrams for another week, and then finally one tries to get down to a maintenance dose of about 200 milligrams per day. Amiodarone has important interactions with warfarin and with digoxin, and one would need to decrease the dose of those two drugs when we use amiodarone. The significant organ toxicities that amiodarone has is related to the thyroid gland. One should obtain a thyroid panel every 6 weeks at the time of initiation, and then every 6 months thereafter. One should monitor the liver function test. And then lastly, one should get a baseline set of pulmonary function tests and repeat that if the patient has symptoms. The last strategy to mention is the so-called pillar in the pocket approach. This was initiated in Italy, where first of all you try to see if a large dose of a 1C drug taken in a monitoring condition, such as 400 milligrams to 600 milligrams of propafenone by mouth, or 200 to 300 milligrams of flecainide, given to a patient in atrial fibrillation while you monitor them. If that terminates the atrial fibrillation, then you can give the patient the drugs to use on their own whenever they develop an episode of atrial fibrillation. But I would emphasize, you should establish the safety of this strategy by monitoring the patient in hospital during the initial trial. The second area that we need to consider is the risk of stroke and stroke prevention. Now, currently, we use the so-called CHADS-VAS score to determine thromboembolic risk. And for each condition, congestive heart failure, hypertension, diabetes, a prior stroke, vascular disease, again, age or sex, we award points if the patient has any one or more of these conditions. Note that there are 2 points assigned to age. One if age is 65 to 75, 2 if the age is 75 or greater. And also 2 points are assigned to the presence of stroke or TIA. On the far right is shown the relative risk, and you can see that when the cumulative risks, the column on the right shows cumulative risks. So if you have a score of 7 or more cumulatively, then your risk of having a stroke increases substantially, 7-fold. On the right is illustrated the factors that may be associated with bleeding. These include hypertension, abnormal renal or liver function, stroke, prior bleeding, the presence of a labile INR, age greater than 65 years, or the use of drug or alcohol. Now, if the patient has one or more of these factors, It is not that you should not use anticoagulation, but rather that you should be careful and follow the patient more closely. This slide provides further detail on the actual application of the data to prevent thromboembolism. At the very top, we note that if the patient has a mechanical heart valve and moderate or severe mitral stenosis, then one should proceed directly to a vitamin K antagonist, meaning warfarin. Note that this does not say that all patients with valvular heart disease should receive warfarin. It is only patients who have moderate or severe mitral stenosis that really should have warfarin, or if you have a mechanical cardiac valve. If the patient has a bioprosthetic valve, then that is not an indication to use warfarin necessarily. Based on the CHA2DS2-VASc score that I discussed in the previous slide, one can make a determination as to the approach to thromboembolism prevention. If the patient has a score of 0, then no antiplatelet drug or anticoagulation is necessary. If the CHA2DS2-VASc score is 1, oral anticoagulation could be considered, but not necessarily given. For CHA2DS2-VASc score of 2 or more, then oral anticoagulation is always indicated. Fortunately now we have the options of the new oral anticoagulants, which I shall discuss in a separate slide, or warfarin. The new oral anticoagulants have the benefit in that they do not require regular testing of the coagulation status, and also there is not significant dietary interaction. The biggest issue that we find here in the United States is cost. Because these drugs have been recently introduced, their costs tend to be very high. Lastly, for completeness, I'll mention that in some patients, one has a contraindication to the use of oral anticoagulation, or the patient has very labile INR. Under those circumstances, it is possible to exclude the left atrial appendage, either percutaneously or at surgery. We have limited data on the effectiveness of this strategy in preventing thromboembolism. I've summarized some of the properties of the non-vitamin K dependent oral anticoagulants in this slide. They include the bigatron, which is a direct thrombin inhibitor, then the 10A inhibitors, rivaroxaban, apixaban, and edoxaban. Note that many of these drugs are excreted by the kidneys. In particular, in the case of the bigatron, 80% excretion. For rivaroxaban and apixaban, significant excretion by the kidney, and also that in the case of edoxaban. And given the doses below, it's important to mention that there are exclusions about the use of these drugs depending on your renal function. So you can see roughly with a creatinine clearance of 30 or less, we recommend exclusion of most drugs. In patients with chronic kidney disease, one can make some adjustments to give a lower dose if you think you definitely want to use the drug. These drugs have been thoroughly investigated in clinical trials, and it is now apparent that at least 2 of the drugs, the bigatron and apixaban, have been associated with a reduction in major hemorrhages, including intracranial hemorrhage, when compared with warfarin. I'd like to spend the last few moments speaking about atrial fibrillation under special circumstances. These include atrial fibrillation complicating acute coronary syndrome, atrial fibrillation complicating congestive heart failure, atrial fibrillation and hypertrophic cardiomyopathy, postoperative atrial fibrillation, and atrial fibrillation complicating the Wolff-Parkinson-White and other pre-excitation syndromes. The incidence of atrial fibrillation in acute coronary syndrome ranges from 10 to 20%. New onset of atrial fibrillation occurring at the onset of an acute coronary syndrome event is associated with an increased mortality risk with an odds ratio of about 1.2. We recommend direct current cardioversion if there is hemodynamic compromise, continuing ischemia, or inadequate rate control in the presence of an acute coronary syndrome. IV beta blockers are useful to slow the heart rate in the absence of overt heart failure or a bronchospasm. For patients requiring anticoagulation and antiplatelet therapy, we can consider omitting aspirin as a second antiplatelet agent because this increases the risk of bleeding. And now there are some trials that suggest that the use of just a single antiplatelet agent, like the P2Y12 inhibitors, ticagrelor, can be used with an oral anticoagulant and provide the same risk as dual antiplatelet therapy would. Some comments about atrial fibrillation complicating heart failure. A direct relationship exists between the prevalence of heart failure and its class and the occurrence of atrial fibrillation. In patients who have New York Heart Association class 1 failure, the prevalence of atrial fibrillation is about 4%. In class 4 failure, the prevalence goes up to about 40%. For patients with compensated heart failure, the rate control options include beta blockers, the calcium channel blocker diltiazem, digoxin, or amiodarone. In decompensated heart failure, one may use a low dose of a beta blocker plus digoxin. You should avoid the use of diltiazem because it can actually worsen the heart failure. And amiodarone and digoxin can provide heart rate control in patients who have decompensated heart failure. Lastly, one should be aware of the occurrence of tachycardia-induced cardiomyopathy. If you're ever presented with a patient who has persistent atrial fibrillation and a reduced ejection fraction, you need to make sure that the reduced ejection fraction is not the result of persistent atrial fibrillation. And so one should attempt to control the rate and restore normal sinus rhythm before concluding that the patient indeed does have a permanent reduction in the ejection fraction. The next category of conditions to consider is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, atrial fibrillation is poorly tolerated in hypertrophic cardiomyopathy. The reason that in the normal heart, 80% of cardiac filling occurs passively during diastole. With hypertrophic cardiomyopathy, the compliance of the ventricle is markedly decreased, and so more and more filling is dependent on atrial systole. When atrial fibrillation occurs, that atrial kick is lost, and one can see a profound deterioration in symptoms in patients with hypertrophic cardiomyopathy. The drugs amiodarone and disopyramide have been particularly good in helping to maintain normal sinus rhythm in patients with hypertrophic cardiomyopathy. Indeed, some patients with hypertrophic cardiomyopathy have been treated with disopyramide even in the absence of atrial fibrillation. Lastly, it's important to emphasize that oral anticoagulation is indicated in hypertrophic cardiomyopathy, independent of what the CHA2DS2-VASc score is, because of the high prevalence of thromboembolism. Atrial fibrillation complicating the Wolff-Parkinson-White syndrome. There's a risk that atrial fibrillation can progress to ventricular fibrillation in patients who have an accessory pathway that conducts in an antegrade direction, meaning you see a delta wave on the electrocardiogram. There are a number of factors that predict the possible occurrence of the transition from atrial fibrillation to ventricular fibrillation. If the refractory period of the accessory pathway is less than 200 milliseconds, or an easier thing which you can actually measure on the electrocardiogram, if the minimum R to R interval in atrial fibrillation is less than 200 milliseconds, then that poses a significant risk of the AF to VF transition. Patients with multiple accessory pathways are also at risk of AF to VF transition. And you can identify the presence of multiple accessory pathways by seeing multiple patterns of pre-excitation in the same electrocardiogram. If a patient has if a patient has Wolff-Parkinson-White syndrome and there's hemodynamic compromise, then you should proceed rather to DC cardioversion immediately. If patients are hemodynamically stable, then you can use intravenous procainamide or intravenous albuterol. Lastly, and most importantly in this category, there are certain drugs that are contraindicated in the presence of pre-excitation, including IV adenosine, digoxin, and calcium channel blockers, and also intravenous amiodarone. We see patients referred to Duke Hospital after they have been resuscitated from a cardiac arrest. Most often, if they have pre-excitation and they come into medical care, there's something that the physician does, some drug that the physician uses that causes a transition from AF to VF. And so one should pay particular attention to these contraindicated drugs. The last category to mention is postoperative atrial fibrillation, and this is a big problem. The prevalence following cardiovascular surgery is between 25 and 50%. The occurrence of atrial fibrillation postoperatively increases the stroke risk, the hospital stay, and the cost. Pre-treatment with beta blockers or with amiodarone may decrease the prevalence of postoperative atrial fibrillation. And lastly, there have been some small studies that show that the administration of colchicine cuts the prevalence of postoperative atrial fibrillation by as much as 50%. Let me summarize a few points about atrial fibrillation and then we throw it open for discussion. Atrial fibrillation is a chronic illness that can be managed. Its prevalence will increase as the population ages. The patient's symptoms should be the driving force behind the therapies that we select. And then at each intersection of the choices of management of the patient, bear in mind that we have very good choices and the decision as to which direction to go with the patient should be guided by a discussion between patient and physician. I'd be happy to start taking questions now.
Dr. Augustus, can you hear us?
Yes, I can.
Well, it was a wonderful talk.
Thank you.
You have covered extensively, and I think you almost accomplished some impossible task. I was wondering, how could you cover so very much with just 20 to 25 minutes? It was a wonderful presentation.
Well, thank you.
We are delighted to listen to your talk. At this stage, I would like to get our colleague, Shirish Hastak, his neurological perspectives, in the context of atrial fibrillation, maybe more specifically, the stroke that can be associated with atrial fibrillation. Dr. Augustus, can you hear me?
Can you hear me now?
No, I can't.
Yeah. I think you are able to be audible now. Yes.
Yes. Dr. Augustus, lovely presentation. Thank you. And very extensively looked at from the cardiac point of view. As a neurologist, I think what happens is that we see these large strokes, big infarcts in the brain. We see the arteries that are clean and the aorta clean, and the heart appears clean and the ECG is okay. We suspect there might be an atrial fibrillation underlying. So would you like to comment on, can the other ways to look at atrial fibrillation, other than an ECG and a pulse directly? Because, I think we need to understand, can we do better than what we are doing?
Okay, that's an excellent question. And it brings up the whole issue of cryptogenic stroke.
Right.
Patients who, for no apparent cause, develop a stroke of the type that you have described.
Correct.
What we're doing here, and these studies have been done by other investigators, is to, number one, do an echocardiogram and make sure that interatrial septum is intact. Because some patients may have a small patent foramen ovale that can be a basis for paradoxical embolus to the left side and a cause of stroke. Right. And the next thing that we do is we use ambulatory monitoring frequently. And to the extent we may either use a 30-day recording, or in many patients, we now implant a loop recorder that can record for up to 2 years. And we get a significant return of first identification of atrial fibrillation by these periods of extensive monitoring. So those are some of the strategies that we use. Echoes to be sure, echo with a bubble study to be sure that interatrial septum is intact. And then, as I said, long-term monitoring, including implantation of a recorder.
Yeah, but Augustus, I think both these approaches, going so aggressively behind to dig out and to try to change the definition of a cryptogenic stroke and to blame something, for example, a small defect across the interatrial septum or a period of an atrial fibrillation during the long-term monitoring, and then pursuing behind them, I think at this point in time, I believe we still have a question mark.
Yes, true.
We really do not have the answer. How do we go behind these two? They can be incidental. The PFOs can be so very incidental. Right to left shunts with the maneuvers can still be present in the normal people.
Yes.
And AF being so very, very common with this kind of a monitoring, and stroke being also common, the causality of these two entities, I think we require a little more reservation in pursuing behind these two issues.
Yeah,
I agree with you.
Dr. Augustus, I want to make a comment. Would you look at the left atrial size and think about that, and the left atrial echo contrast? Maybe look at the NT-proBNP or some blood markers, which may allow us, because it's sometimes extremely difficult to accept, that this is cryptogenic when there are large infarcts, sometimes bilateral infarcts in the hemisphere.
Yeah.
And we're not picking up anything. So what is your opinion on these techniques like the, that I mentioned?
Well, if one sees, the things that you mentioned, we may find them positive, but it brings back to the original point that was made just now, and that is that these things like spontaneous echo contrast or proBNP, we may see those elevated, but we do not have enough data to be sure that these are pointers to the presence of a higher stroke risk. The situation there is that we really do need more data.
Perfect.
Right. What about this concept that if you have you just have a few seconds of atrial fibrillation and then can't document anything, and so is that 30 seconds cut off, anything evidence-based, or is it just something that we have arbitrarily thought about amongst ourselves? I don't know. Is there evidence for that 30 seconds cutoff, or is it just
Well,
for
no,
the
we're still trying to get some more data on that. And in particular, there are at least 2 studies now that are looking at patients who have implantable electronic devices, like the neuro ICDs or pacemakers, that can record high-rated atrial episodes. We know that we have these devices in patients who, on the surface electrocardiogram and from prior history, they do not have atrial fibrillation, but sometimes we see these high-rate atrial episodes. To date, we are not sure how long those episodes need to be occurring before we can say there's an indication to anticoagulation. Some people are saying no, that if you see high-rate episodes that last more than 4 hours, then that's an indication to anticoagulate. But we need more trial data to show that that's the case.
Right.
Shirish.
Yeah, go ahead.
Now, tell me your approach. Now, you and your colleagues, define this as a cryptogenic stroke.
Right.
Yeah. Is that all? You will use some antiplatelets, and is that all? Or how do you respect AF as a cause of that stroke?
Right. I think the first thing we try to sort of define is, the clinical syndrome itself. So if the clinical syndrome of stroke is like a large stroke, like a big stroke with a high NI stroke scale, or is a stroke, what you call as a rapidly vanishing deficit, or the type of stroke is multiple in the hemispheres. And then, of course, we look at the arteries. So if the arteries, the carotids, the internal carotids, and the aorta are clean and don't show anything, then of course we further, and the age of the patient is not in the atherosclerotic, zone. So relatively younger patients, we would, pursue the cardiac, sort of angle much more carefully. And maybe, as I said, we do NT-proBNPs of these patients, try to find out if we have a reason to monitor them for longer periods. Because in India, I think you are well aware, doing that, Holter for more than 7 days, at least in my setup, it's usually a 7-day Holter at the most. You can't do a persistent Holter beyond 7 days because of the cost limitations. But if we are clinically suspecting a cardioembolic stroke based on the pattern of infarcts in the brain as well, the clinical syndrome, the arteries being clean, and then we look at the aorta clean, and then we look at the heart much more carefully.
All right. So basically, you would like to pursue and then try to figure it out in your own limitations of the practice, whether the AF was actually contributing, because anticoagulation versus antiplatelets is going to make such a huge difference. So to an extent, with the available resources, with the available evidences, you make some modified approach from your own viewpoint. Dr. Augustus, I would like to raise a question to you. Just because a trial realign kind of gave a picture of dabigatran being not okay in that phase 2 trial, is that the end of NOAC future with respect to the mechanical walls or the rheumatic heart disease? Is that the end of an era of thinking about dabigatran or any other newer oral anticoagulants? Is that all over?
Yes, I personally think that in terms of the mechanical valve, right, I do not think there are going to be any trials on the mechanical valve that are going to be done with any of the specific inhibitors, such as the 10A inhibitors or the direct thrombin inhibitors, because the problems that have arisen with those trials, when a problem does arise, can be catastrophic. You can actually get thrombosis of the mechanical valve. And one trial that was looking at that with the dabigatran had to be discontinued because of the thromboembolic risk that was associated with its use. And bear in mind that the population that would be candidates for receiving some other drug is not very big at all. And so the pharmaceutical industry is not going to devote a lot of resources to identify an agent which works well in patients.
Yeah. So I think you pronounced your fear. It is the pharmacological industry which is not going to sponsor these kind of trials.
Yes.
Right. But you know, there are sponsors who may not be always necessarily the pharmacological industry. Yeah. I think if at all, if there is some trial that is required to be again tried, is this newer oral anticoagulants in these mechanical valves, in these rheumatic heart disease, because what is actually bothering the Indians is this rheumatic heart disease.
Yes.
I know that the bioprosthetic valve in the first 3 months.
Yeah.
You know, more patients are dying because of warfarin.
Yeah.
You know, if you conduct a trial, you would probably come out with the data saying that the mechanical valve and the bioprosthetic valve and the AF, they live longer without warfarin than with the dual antiplatelets in our country.
Yeah.
This is my hypothesis. This is my hypothesis.
Yeah.
You know, in a center like ours, in a month, we get not less than a dozen people who have come here because of their warfarin.
Really?
That's it. It's because it is impossible in our economic and social situations to monitor INR.
Yeah, Dr. Ullas, is it? I agree with you, Dr. Ullas, that we do have a lot of trouble getting the INR in the therapeutic range. Right. Is it related to our diets and the type of?
See, you can propose as many possibilities. I would agree with all that, but the point here is warfarin is not okay for us.
Right.
For many reasons. And just phase 2 trial with all that limitations of that trial and with all the critics of that trial, I do not think we should just be not dependent on the sponsors. We should create your own federal funding, our own government funding. There are many people who can fund. Because it has to be brought to the notice that the warfarin is not good for specifically the Indian population.
Well, let me make one other comment, by the way. Another issue to consider, and I think this may be an important avenue, is the design and material that the valves are made of.
Absolutely.
There's one valve currently now that has been approved by the FDA,
yes,
in which they are trying to see if the NOACs can be tolerated at that particular valve.
Correct.
And maybe that may be the approach that we should take.
Absolutely. So it is. Sorry. Yeah, absolutely. I think, Dr. Augustus, you should visit India. You should really look the kind of atrial fibrillation issues, the rheumatic heart disease issues, the mechanical valves issues, and if you are talking about AF and an anticoagulation, I think your inputs are very much required here. And claiming realign, proved that dabigatran is not okay. Somehow I'm unable to digest that. I think we require more trials and more bold people who can sponsor this kind of an observation. Shirish, would you like to ask him another question, or can I go ahead with another one?
Sure.
Shall I go ahead?
Yeah, Ullas. I just wanted to ask Dr. Augustus a question about, it looks like, amiodarone is a pretty, important sort of molecule from the cardiac point of view. And the problem, of course, with amiodarone is that with NOACs, it can create a lot of problems because of blood levels of NOACs. And it would do similarly with warfarin, I guess. But the only advantage of warfarin would be you could track it by doing the INR, whereas you could not track it with a NOAC. So what's your take on that? I mean, does that happen very frequently?
We see very few clinical interactions between people who are taking a NOAC plus amiodarone. We're aware of the potential interaction, but we see very little of significance in terms of interaction between those drugs. Whereas with warfarin, we do see significant interactions. INR is becoming very high, 3-4-fold higher, but not with the NOACs.
So Shirish, I too agree with Augustus. You know what, among the available antiarrhythmic drugs, you know, in the AF context, people have less of a confidence in propafenone, which is available, flecainide, which is available, sotalol, which is available. But then people have more confidence in amiodarone, and Augustus had clearly demonstrated and told where you use. But if there is this clinical situation where dabigatran and warfarin is there, we really are not so very scared because the experience is large where the dose adjustments are not a major problem.
Okay.
Yes.
Dr. Augustus, you know, yeah, I don't know whether we have some more time, but this could be the last question from my side, unless my colleague Shirish has. Okay, now, I could hear you from your presentation that when it comes to the atrial fibrillation patient who undergoes the PCI, at the time of the PCI, you know that this patient is known to have atrial fibrillation. Or soon after the PCI, you think that he also has a atrial fibrillation.
Yeah.
You see, maybe for 3 months, I think, you know, we should follow, you know, triple drug regimen, you know, it may be okay. But, you know, let's think about after 3 months in general, okay, bare metal versus drug-eluting, you know, most often it is a drug-eluting.
Yeah.
You know, in your viewpoint, you know, the guidelines are still are not very clear about it. Do you recommend a NOAC and a clopidogrel to make it simple, the prescription? Or you still would like to, you know, make some more comments? No, you can use warfarin and also clopidogrel, or you use specifically this particular NOAC and this particular P2Y12 inhibitor. I want you to make one simplified statement after 3 months of a PCI with the AF. You know, I know that, you know, it is not in the guidelines presently, but I want you to tell your practice or what you advise the interventional cardiologist.
I would say that if you use an oral anticoagulant and a single antiplatelet agent after 3 months, the preliminary studies are available that says that patient does well with a single antiplatelet agent. Now, the other side of that too, in choosing the stent that you put in, one needs to bear in mind that if you are using a drug-eluting stent, then you may be committing yourself, at least for the first part of therapy, of using dual antiplatelet therapy with a DES.
No, but I'm not still clear. What is your prescription? Actually, what is the prescription? I want you to be a little more specific. Which anticoagulant? Which antiplatelet?
Well, in the acute setting, we will still come out and mention ticagrelor for the antiplatelet agent. And then for the oral anticoagulant, it depends on the circumstances of the patient, particularly renal function, whether we'll recommend apixaban or rivaroxaban. We tend to use more apixaban and rivaroxaban than we do dabigatran.
Fair enough. Okay. Even though we do not really have any data here, but I think it makes a lot of sense. You chose the most effective antiplatelet, which is the most convenient and compatible with the clinical situations, and you made a little bit of a clinical discrimination, renal failure or no, and then you choose among two of them. One was apixaban and the rivaroxaban. You almost left out dabigatran and edoxaban. Fair enough. You know, I think, you know, that probably is your expert opinion in this, and I take it wholeheartedly. It was wonderful, Augustus, and
yeah, I had a question.
I learned a lot from you both.
I had a question for Ullas. I had a question for Dr. Augustus. You know, I mean, amongst the NOACs, we understand that there is no head-to-head comparison. I mean, they've been all compared with warfarin, which is the standard of care. But if you look at the molecules and sort of postulate from the molecules physiology and pharmacokinetics and the trials all put together, would you say that dabigatran, to some extent, the 150 BD would have best evidence for stroke prevention? I'm of course simplifying it, but I'm simplifying it for the sake of going through the complexity that you have gone through. Maybe look at dabigatran 150 BD as a stroke prophylaxis drug, and look at rivaroxaban because it has some evidence that cardiac failure and cardiac patients benefit more from rivaroxaban, and some evidence that maybe the apixaban would be with the renal dysfunction patients, and so on. So a little tendency towards using these based on, so I've simplified it as a thought that this is a neurologist drug, a cardiologist drug, and a nephrologist drug, just oversimplification, of course. But what's your opinion on this, little bit of biases that may come through with the trials?
Well, I think that the data on stroke and apixaban and rivaroxaban are fairly strong in the sense that there is less risk of major intracranial bleeding with those agents, even compared with warfarin. And so I am biased in that regard. I do not treat a lot of patients who have strokes independent of heart disease, so it's difficult to comment on considering dabigatran as a stroke drug in absence of atrial fibrillation and other causes of strokes.
Though you think that because the 150 BID of dabigatran seems to have as if not stronger than apixaban signal for the 5 milligram BD apixaban signal is the dabigatran seems to have a stronger signal in stroke prevention, but that's based on prevention of strokes overall, hemorrhagic strokes and ischemic strokes in terms of 150 BID. So that was the impression that the neurologists a little bit carry in their mind, but maybe apixaban is as strong. But from rivaroxaban, do you carry this little impression that with congestive heart failure and with cardiac problems, rivaroxaban would be a little better? And of course, apixaban is certainly better when you have renal dysfunction and, creatinine clearance less than 30 ml per minute and so on. So where, of course, if it's really low, you would consider warfarin.
If we still have a problem with patients who are on dialysis or who have stage 4 renal disease. It seems that if the patient is actually on dialysis, we really should be treating them with dose-adjusted warfarin. And the incidence of bleeding is significant in patients on hemodialysis. If the creatinine clearance is as low as 15, one can actually reduce the dose of apixaban and still get effective thromboembolism prophylaxis. Recall that apixaban is 75% metabolized in the liver. And so to a creatinine clearance even down to 15, you can get reasonable control with apixaban.
Hi, Shirish. So thanks very much. Actually, as long as you admit that there's no head-to-head trial, you can make it as much simplified or as much, personal opinions and all that. But it's a good news that, we have newer oral anticoagulants and we have an expert like Augustus, to tell us how do we go about it. It was wonderful, Dr. Augustus, hearing you. Shirish, your inputs were no less than any cardiologist, by the way, the way you analyze things. And it had been a wonderful evening for me. And those people who watch this, those people who are going to watch this, I think they are going to be immensely benefited. This is my thinking.
Just one point, Ullas. Dr. Ullas, can you take the questions from the link? I think They're asking.
No, I think more than me, Augustus will be pleased to listen to those questions.
I mean, of course, directed to Augustus, but you could.
So it is directed to me. I would look at the chart, I believe. I don't know. There's nothing here in my chat. What was the question, by the way?
No, I thought I got information that you would get the questions.
Yeah, so I'm seeing here in my chat box, there's nothing.
Okay. So we're looking at our chat box. Just give us a second.
Sure.
Because this is a great opportunity.
And at least
There is a question from Delhi, Abhi Malhotra. In your opinion, how significant is the association between fibrinogen and ischemic stroke, suggesting that coagulation system could be implicated in thrombosis-related ischemic events like thromboembolism and atrial fibrillation? I think,
That's a question for you.
Yeah, this is a question for me.
Sheesh, go ahead.
Yeah.
This is truly pathology question here.
Yeah, sometimes we look at the FDP, the FDP levels, and think about whether this stroke is, cardioembolic or, has some procoagulant state and so on. But these have not been really proved to date. Sometimes in malignancy and strokes, we have looked at FDP and found them to be high, or the D-dimers is another thing that we have sometimes found them to be high. But I think it's not yet proved, so it remains in the open space.
Yes.
Yeah. So the second question is, to which segment of patients would you suggest a pill in the pocket method of treatment? That's from Ilu Naidu from Hyderabad. That's to Dr. Augustus.
Yes.
Yeah. I would say if the patient has fairly rare episodes of atrial fibrillation, perhaps 2 or 3 per year, and has no significant underlying structural heart disease, and the patient is reliable, then I'll go ahead and try the pill in the pocket in the cardiology department or the emergency room once. And if they tolerate it, then I'd go ahead and let them try it. So few episodes and somebody that is reliable.
Yeah. So Dr. Augustus, now I can tell you the problem in advising this to Indian community. I'll tell you the problem in this.
Yeah.
First of all, you define this patient on the basis of several things. How many times he has had in the last 1 to 2 years. And then you made an average that it is occasionally, it is rarely, 2 or 3 episodes. And then you made an observation that he is going to be compliant. And you did not mention that this pill in the pocket needs to be tested in the environment of observation, preferably in the CCU, some ECG pre and post. Yeah. All these things are just not possible. Okay.
Really?
Easily.
Really?
Yeah. So the pill in the pocket is such a nuanced exercise. I think there needs to be a reservation in prescribing this.
Yeah. Okay.
This is, if you ask me, this is the theoretical practice. When it comes to real practice in India, we have less people, less patients to whom we can prescribe this.
I would just say, even in the US here, we rarely do it.
Exactly. I think that Italian study is good, well conducted. It gets into the guidelines. But the pill in the pocket, I do not think is such a great weapon there. If there has been a termination of an episode, it was like placebo, maybe.
True.
So, I have my reservations about the pill in the pocket. But if you still insist, you need to come to India, Dr. Augustus, because these guidelines are actually meant for the compliant, the educated, the people who would understand what is it. But pill in the pocket in India, you need to come and then figure it out. This probably should not be even mentioned in our books.
Okay.
Yeah, the question I have for Ullas is, what is the bill in the pocket also in that pill in the pocket?
No. I think paisa in the pocket makes a lot of sense than pill in the pocket. I don't think that's really a good we need to be really looking at whether it works in India.
Okay. Fair. There's a question to Dr. Augustus, which is atrial flutter versus atrial fibrillation. How do you, clinically decide, and will it change management and so on?
Well, in terms of the issue of anticoagulation, the decisions are exactly the same between atrial flutter and atrial fibrillation. In other words, the indications for thromboembolism prophylaxis is identical for atrial flutter or atrial fibrillation. To a certain extent, atrial flutter can be more problematic with drugs because if you give a class 1 drug, 1C drug, to a patient with atrial flutter, it may slow the ventricular response, slow the atrial rate from say 300 to 220 minutes. And the patient might change from 2-to-1 block in atrial flutter to 1-to-1 conduction. And the ventricular rate may actually increase in patients with atrial flutter.
Yeah. So one comment here, Shirish.
Yeah.
If you have distinguished the arrhythmia as an atrial flutter and an atrial fibrillation, if you're quite sure, I think the management would be quite different in the Indian scenario. See, the flutter ablation can yield more gratifying results than a fibrillation ablation from the Indian perspective.
Right.
So, with all that, flutter patient can be subjected to a little more liberally for an ablation therapy.
That's a very important point, Dr. Ullas. Thank you. There's another question to both of you, which basically says, what are the advantages or what are the pros and cons of electrical cardioversion versus pharmacological cardioversion? I think you could give the Indian perspective and Dr. Augustus could give the perspective from his country.
No, I think the perspectives, I think are going to be almost same from both of us. You see, I think the DC cardioversion opportunity should never be missed. It all depends on, how aggressive you are. Because Augustus has already told, if you maintain the patient in atrial fibrillation longer, he's going to have a more problem. But if you want to break that and then try to attempt to bring it into the sinus rhythm with whatever that means, DC cardioversion or a pharma conversion, I think it's kind of a good medical practice. However, Augustus already had mentioned, if it is more than 24 or 48 hours, if you are not certain what is the duration, you may create more harm in a DC cardioverting or a pharma conversion because there is a small chance of thromboembolism leading to catastrophe. So do not lose the opportunity to do the cardioversion, either with the DC cardioversion or a pharma conversion. Take the precautions of anticoagulation, do the TE if it is possible, etc. And then Augustus highlighted one more point, and that is prepare the patient to be amenable for cardioversion by giving an anti-arrhythmic therapy beforehand. Maybe I might have wrong. He mentioned even ibutylite. I think whoever asked the question should be encouraged. He shouldn't have much of a reservation to try to maintain the patient in the sinus rhythm. If you cardiovert him, he living in the sinus rhythm for a longer time is going to be more a possibility. Augustus.
Well, personally, I always try to restore normal sinus rhythm at least once in a patient. I am convinced that in general, patients do better when they're in sinus rhythm and they feel better. There is an odd patient, usually elderly, who is not very mobile at all, doesn't do much outside, and has relatively slow rates in atrial fibrillation. And in those individuals, I may come to accept atrial fibrillation as their standard rhythm. But I think it's almost always worth trying to get the patient in sinus rhythm. I'd like to follow up on the comments that you and I made about atrial flutter. The one thing I'd say is that in some patients, if you see both atrial flutter and atrial fibrillation, sometimes if you ablate the atrial flutter, that may actually substantially decrease the frequency of the atrial fibrillation, because atrial flutter can drive atrial fibrillation sometimes. So,
thank you. There's a question to you, Dr. Augustus, which is that how do you prevent post-operative atrial fibrillation? I assume it is in relation to a cardiac surgery, but how do you prevent it? What's your take on that?
Well, there are a few things that have been shown to be of value. The first of these is that if the patient is taking a beta blocker preoperatively, then if you can, you should maintain the patient on the beta blocker through the operation. There's one problem with that, and that is that very often in our surgical intensive care unit, when the patient gets out of the operating room, they're using a lot of inotropes that are sympathomimetic agents. And if you have a patient where circumstance is going to occur, then the beta blockers are not going to be as effective. And then, again, some individuals give amiodarone, again, prophylactically, to prevent the occurrence of atrial fibrillation. Our approach, if the patient does go into atrial fibrillation, is to focus on controlling the ventricular rate in the postoperative period, because very often the factors that precipitate atrial fibrillation in the first place are still present. And if you kind of hurt the patient, it's not going to be enduring. So we usually wait until the patient is ready to leave the hospital and then consider calibrating them then, rather than, in an acute situation within hours of coming out of the operating room, because they go back into atrial fibrillation right away.
Okay, this is the last question I'm taking from Rakesh Mehra, Mumbai. What is your opinion on atrial fibrillation being hereditary? Dr. Augustus.
Yeah, that's a very good question. There are good data now showing that atrial fibrillation can be inherited. And what has been demonstrated is that certain individuals may inherit abnormalities of membrane ion channels, in particular potassium channels, and that may be associated with the occurrence of familial atrial fibrillations. The things to watch out for is atrial fibrillation occurring in a relatively young age, like less than 50 years in the absence of heart disease, and atrial fibrillation occurring in multiple family members. If you see those two things, then it suggests that atrial fibrillation is probably familial. Now, having decided that, we still don't have a lot of data yet to tell you, is there any specific approach that you should use to treat the atrial fibrillation if it's familial? All we can say is that there's this association between inheritance and the occurrence of atrial fibrillation.
I just had a last comment, Dr. Augustus, is that, we were looking at infective endocarditis as a mechanism of stroke, and we found that you could do an ultrasound or a CT of the abdomen and see emboli in the spleen and say that this is infective endocarditis mechanism of stroke. Can we do a similar thing for atrial fibrillation? Just an extrapolation, because you have systemic emboli, you're missing them. You're only picking up the cardiac emboli, and you don't know what's the mechanism, and it can make a big difference.
To my knowledge, I'm not aware of that being done, but it's certainly a good idea.
Because you are missing the systemic emboli, and we're getting the brain emboli, and we don't know where they're coming from. So maybe we'll look at the spleen and make out that they're coming from the heart or the aorta or their proximal, sort of embolic disease.
Yeah.
Dr. Ullas, your last comment.
Yeah, well, you see, the good thing about such interactions, expert like Augustus, who I do not imagine I would have, spoken to him such a long time, one-to-one, and the people audience. You see, this has opened up the several questions today. The last one was you hypothesizing, how do we make imaging as to look at atrial fibrillation could have been the cause for the stroke? Yeah, absolutely. I think, there is a multi-modality of imaging is required. We need to be conquering this atrial fibrillation problems.
Yes.
The things which we have, we probably are not using it optimally. There probably is a scope for them to be used a little more extensively. There is a scope for research, especially in India, with respect to warfarin. And Dr. Augustus, we remain grateful to you. Your presentation was extremely useful, and I'm sure the host had really done their great job. They have roped in many people who have been watching this show, and maybe they will watch later. And I and the host and Dr. Shirish, thank you very, very much.
Thank you.
Well, thank you for inviting me. I appreciate it.
Thanks.
Take care.
Thank
All
you,
the best.
everyone. Bye.
Bye, Shirish.
Bye.
And I hope to meet you soon.
Yeah. Thank you. Bye.
Bye-bye.